So good afternoon, everyone. As Sherry said, my name is Gerald Williams, and I am the Senior Patient-Centered Care Consultant for Amerigroup, Georgia. Very excited to be here with you today. I want to thank Hometown Health and the Georgia High Tech team for having me present today. And I also want to thank all of you for joining in to learn more about patient-centered medical home implementation and the benefits of both recognition and sustained transformation. As Sherry pointed out, we do have some learning objectives for today's presentation, and they are as follows. We will define the patient-centered medical home model and just kind of provide a better orientation for exactly what the model is. We'll understand the benefits of implementation for patients and providers, and so try to get an understanding of what's the value added for both parties. We'll observe the national and local footprint for patient-centered medical home recognition. We'll also describe the current reimbursement landscape for PCMH recognition in Georgia. And we'll also highlight some of the upcoming changes to patient-centered medical home 2017. The standards and guidelines are getting ready to change in 2017, along with the recognition process. So we'll provide some early updates there just to make you aware of what's to come. And then last but not least, we'll provide an overview of some of the PCMH support services here in Georgia. So what exactly is a patient-centered medical home? At the end of the day, patient-centered medical home is a healthcare business improvement model that's developed a lot of inertia in the primary care arena as being a highly effective model for improving quality, reducing costs, and enhancing the patient experience. So how do we do this? How do we accomplish this triple aim? Well, we accomplish this triple aim by focusing on some key areas. First and foremost, we reestablish the importance and value of the primary care provider care team as the conductor for personal health. Here, we really want to ensure that every patient has an assigned primary care provider and that the practice is monitoring continuity of care, meaning what percentage of patients are actually seeing their assigned primary care provider when they come in for visits. And this is a very important concept because there has to be value in seeing the same person for a need as personal as healthcare. And if improved patient compliance and positive health outcomes are the goal, then we have to start by building trust, which is first accomplished by having an assigned primary care provider. Next, enhance patient access. Here we want to ensure that practices have adequate supply for the growing demands of their patient population, such as same-day appointments, alternative clinical encounters, patient portal access where patients can request referrals and test results. They can request clinical advice for non-emergent situations. We want to make sure that practices are having defined appointment types and they have a standard for wait times for patients to access those appointment types. And lastly, after-hour access and availability. We want to make sure that patients have an opportunity to be seen after hours. Next, it emphasizes the importance of population management. A key component of becoming a recognized medical home is demonstrating the capability to use your EHR system as a tool to conduct proactive patient care and outreach. And by doing so, practices are much better positioned to improve quality, reduce avoidable hospitalizations and ER visits, and enhance earning potential in various pay-for-performance programs. Next, we have care management and active partnership. We want practices to establish a criteria for patients who are candidates for care management and conduct comprehensive health assessments at relevant visits, provide care plans that involves the patient and considers their preferences, and also monitors medications to ensure compliance and safety. Next is coordination of care. Here, the expectation is that practices are integrating operational processes to achieve seamless care transitions. And this is accomplished by what I like to call TFF, track, flag, and follow up. We want to make sure that practices are tracking, flagging, and following up on lab and imaging orders and ensuring timely communication of test results. Same thing with referrals, TFF, track, flag, and follow up on overdue referrals and ensuring timely exchange of patient information. And lastly, we want practices to observe performance on key clinical measures, utilization measures that affect costs, and care coordination measures. And we also want practices to be observing patient feedback, from patient surveys, to really be able to identify opportunities to set goals and assign appropriate interventions to make sure that they're meeting those goals and that they're improving on a continuous basis. And so when we implement all of these key components of the medical home model, we begin to transform from a healthcare delivery system that features no empanelment, where patients don't have a primary care provider, the acute illness paradigm, where we're more reactionary and not proactive, unplanned care, with no patient, we're not having patient huddles or daily huddles, we're observing the daily schedule, or we're not producing care plans that have goals and self-management techniques, lack of evidence-based guidelines in the provision of care, and lack of care coordination, no care compacts, or very little interaction between primary care providers, specialists, and the greater medical neighborhood. The lack of continuous quality improvement. We're using interventions where we don't know if they work or not, and we're not assigning goals to help us, to help guide our efforts as we move towards a better provision of care. Lack of access, inadequate information systems, and lack of enabled team, meaning that we're not using our team. We're treating the delivery of healthcare as a person-by-person basis in terms of staff, and not really using care teams where we're using everyone's expertise to really contribute to a better model of healthcare delivery. So we transition from something that's familiar today to something that's more comprehensive, more coordinated, and more safe for patients to navigate the continuum of care. So what exactly are the benefits of PCMH implementation to patients? Well, first and foremost, they have a better opportunity to receive timely, proactive care and develop sustainable relationships with primary care providers. One of the requirements for patient-centered medical home is that practice is going to have to be able to use their EHR system proactively to identify patients who need certain chronic services, patients who need different preventive services, to identify patients who haven't been recently seen, and patients who are on certain medications. And so by being proactive in how you identify these patients and also creating different operational protocols for how you outreach to those patients, it really gives your patient population a better opportunity to experience positive health outcomes. We also see with patients they have reduced wait times and more meaningful visits, and that's primarily associated with improved cycle times because the practice is operating at a more efficient level. And this can be due to just enhanced communication with the practice, maybe having regular team meetings, having daily huddles where you're giving yourself an opportunity to plan for the day and being able to identify some of the things that can typically derail the patient schedule. All of that will be relative to benefits for the patient. Also, enhanced coordination of care. So another requirement for practices is to establish care compacts, where they're really defining what that care transition process looks like between primary care and specialists, and defining the type of information that needs to be exchanged and the timeliness of that information. So establishing care compacts is a significant footprint in really building the medical neighborhood, facilitating relationships between primary care and specialists, and really creating an atmosphere where it's easy for patients to navigate that continuum. Tailored care plans, right, where the care plans are including the comprehensive health assessment and making observations from medication management to truly create these plans that are tailored to where the patients are. And then last but not least, improve patient outcomes. That's the result of being able to participate in a patient-centered medical home where the practice is operating more efficiently and communicating at a higher level with the greater medical community. So benefits of PCMH implementation to the practice. One of the things that we recognize in our groups that are going through the patient-centered medical home program is that they've enhanced their earning potential and eligibility for third-party incentive programs. So a lot of pay-for-performance programs are built in the same image where they're based on quality performance and utilization. And so by working through the medical home model, making improvements relative to population management, care planning and care management, and care coordination can have a significant impact on how you perform in various pay-for-performance programs. This is definitely a value added that often gets overlooked with the medical home model, is how it helps you to perform in these existing programs. It also helps you generate revenue and improve patient cycle time. So as a result of doing population management or subscribing to different interventions in the practice, like having a call team or having EMR systems that are capable of generating reports of patients who need certain services, All of this helps you to make sure that patients are actually coming to you, to your primary care offices to receive the services, and reducing the likelihood of avoidable hospitalizations and ER visits. Enhances population management, proactive care, and it also complements meaningful use. So about 60 to 70% of the requirements for patient-centered medical home are directly aligned with what meaningful use is asking for. So it's a great opportunity if you already have meaningful use to just expand and build on some of the foundation that you built in that program. It improves quality of care and performance in HEDIS, as discussed, and it also provides the infrastructure for improved communication with ancillary health providers. So one of the foundations, NCQA now has an accountable care organization accreditation program, and the foundation of that program where you can get auto points towards your ACO accreditation is having recognized medical homes. So the medical home is the foundation for the medical neighborhood and the onset of these different accountable care arrangements. So you'll be well positioned if you're approached by different providers or approached by a different group, if you're approached by different payers and also maybe different groups of providers, you'll be well positioned to participate in something where you can share the risk responsibly and ensure great health outcomes for a defined population. Also, operational efficiency. I think this is probably one of the biggest wins for patient-centered medical home relative to practices and providers. You know, the opportunity to work in an atmosphere where it's easier to work there, where everyone is communicating, where the roles are really aligned and the left hand knows what the right hand is doing. Having daily huddles where you can plan for the day and identify patients that may need certain services. Pre-visit planning, streamlining job functions, and creating opportunities for staff to communicate all contribute to an enhanced operations that makes the practice a lot easier to work with and makes it a lot easier to execute healthcare delivery. Reduce staff turnover. Staff members are typically more happier in patient-centered medical homes, and that's one of the things that I've realized working with practices in a heavily Medicaid environment. The staff turnover is an issue. And when practices have high levels of staff turnover, it makes it really difficult to establish a culture, a way of doing business, because we're constantly having this turnover. We're constantly trying to bring everybody into the fold. Well, having defined processes and procedures, being clear about operational, tasks, making everybody's role a little bit more complementary can definitely help make the environment a happier place to work, and in turn can reduce your staff turnover. And in turn, these different things helps to reduce provider burnout, right? If you're working in an environment where staff are happier, you have a little bit more control over the day because you're able to plan. Typically, that helps the day just to go a little bit easier and reduce burnout for our providers. So in terms of the national landscape for patient-centered medical home recognition, this is directly from NCQA's website, and I've been looking at this map probably for the past 5 years. And I remember when there were states on this map that didn't have any patient-centered medical home recognition, at all. Well, just take a look at the landscape now. Every state, in the United States has a recognized patient-centered medical home, which is amazing. And we had, in total, we have 11,388 total sites, that are recognized. And you can look at the eastern part of the United States and really see that these states are really leading the way. If we want to focus on Georgia, this is one of the sites. This is one of the states that has over 200 plus, recognitions, which is tremendous. And so when you think about a landscape of the southeast corridor of the United States and some of the health concerns that are most prevalent, it's kind of encouraging to see that those states are starting to light up with patient-centered medical homes, and that the southeast region of the United States is really subscribing to a more patient-centered approach to delivering care. So just to give you some hard numbers in Georgia on the left-hand side of your screen here, we have 264 sites in Georgia that are recognized. That encompasses 1,079 clinicians. We have 243 practices that are recognized under the 2011 standards and guidelines, and we have 21 practices that are recognized under the 2014 standards and guidelines. And I expect that number for the 2014 recognized practices to really increase over the next year with the conclusion of the program. And that's typically how the program cycle for patient-centered medical home. NCQA releases a new iteration of the standards and guidelines every 3 years, and in between time, every quarter, they make updates where they provide some clarifications for things that already exist, the things that already exist. Well, with the onset of 2014 and the closing of 2011, you saw a lot of practices that were trying to get their survey tools in to get recognized under the 2011 program before it expired, and I expect the same thing to happen at the conclusion of the 2014 program. Also in the state, we have 3 practices that are level 1, 29 practices that are level 2, and 232 practices that are level 3s, which is the overwhelming majority of practices recognized in Georgia are level 3s, which has a significant impact when you think about reimbursement programs. A lot of the incentive programs for patient-centered medical home are going to require practices to be at a minimum of a level 2 in order to be able to take advantage of any incentive programs that are available. And then if you're just familiar with the standards and guidelines, you actually trip on a level, if you're trying to get level 1, you trip on a level 2 along the way. So I definitely think, at minimum, practices should be going for at least a level 2 recognition to truly demonstrate that they're operating at a level of optimal patient-centeredness. The other thing that I wanted to point out on this map are the little yellow dots. The yellow dots represents the number of patient-centered specialty practices that are recognized in the United States. So if you're not familiar with NCQA's products, obviously they have a patient-centered medical home recognition program, but the mirror image of that program is the patient-centered specialty practice recognition. And if you read the standards and guidelines in terms of what are some of the requirements for primary care practices who do the patient-centered medical home program, it's a mirror image to what the deliverables and requirements are for the patient-centered specialty program. However, the program has been a little slow. This program was first introduced in 2013. There'll be a new iteration of the patient-centered specialty guidelines that I believe are expected at the end of the year. But the program has been a little bit slow to catch on, and I think mainly it's because it's not a lot of incentive programs out there or any carrots for specialty practices to kind of engage in the patient-centered recognition for specialty practices. So if you're working on patient-centered medical home as a primary care practice, one of your largest requirements is engaging, the specialist, community. It can also be an excellent opportunity for you to share with them what you know about the patient-centered specialty program, and hopefully bring them into the fold so we truly begin to create those medical neighborhoods. We have 2 patient-centered specialty practices in the state of Georgia. I work with both of these practices. Georgia Hope is a behavioral health practice that's based out of Dalton, Georgia, and also Harbin Clinic, Harbin Oncology Cancer Center, which is also based, which is based out of Rome, Georgia. So those are the only 2 practices in the state of Georgia that are recognized as patient-centered specialty practices. Hopefully, as the years progress, we can see that number improve. So looking forward to 2017, the deadline to purchase the Patient-Centered Medical Home 2014 survey tool is March 31st of next year. And so for those of you who are not familiar with what the survey tool is, the survey tool is the software that you have to purchase from NCQA in order to load all of your documentation, all your processes, all your procedures, all your reports, all your examples, all the documentation that you produce in response to the PCMH standards and guidelines. You use this survey tool to deposit all of those documents. Well, the deadline to purchase that survey tool is March of next year. So you have a year really to purchase the survey tool. The last day to submit that survey tool is September. And then also in March of 2017, you'll see the new iteration of the 2017 standards and guidelines. And just in general, just looking at the differences between 2008 and 2011, the differences between 2011 and 2014, there are always changes. There are always, some areas are completely overhauled. Some areas are just, tightened up in terms of efficiency. And then there'll be some minor places here and there where they may just remove some things. But typically, when the different iterations of the standards and guidelines come out, it moves towards, accountability and making sure that practices are not using this model as an exercise of recognition, but an opportunity to truly transform. Don't wait. If you are not recognized today and you look at that 3/31/17 date, says, oh, okay, well, we just have a year, we have plenty of time left, in order to get the recognition before the new standards and guidelines are released. Please don't do that. On average, and I've worked with a lot of practices throughout Georgia, on average it takes about a year to get patient-centered medical home recognition. And that depends on a couple of things that we'll talk about here, in a moment. But, in addition to seeing patients, and running a healthcare business, this will be something that will certainly be time-consuming, something that you really want to contribute a degree of effort to, because the objective here is to transform. And so you want to give yourself, ample amount of time to make sure that you're meeting the standards and guidelines, that you've implemented certain protocols and processes, within the required time period, and that you're truly integrating the model where you can achieve culture change. So just please keep in mind these dates, because they'll be very important and can really save you a lot of headaches as we approach 2017. So still looking forward to PCMH 2017 changes to the actual model itself, right? And so as I said, enhancements are made to the current 2014 standards. There will be some changes. One of the biggest changes from 2011 to 2014 was the record review workbook. And those of you who may not be familiar with the record review workbook, it's really an opportunity for practices to observe how they're performing in different care planning and care management deliverables. Are you providing care plans? Are you doing medication management? Are you conducting comprehensive health assessments? So the methodology in terms of how that record review workbook is completed was a lot different in 2011 versus what it is now with the 2014 standards and guidelines. Another big difference between 2011 and 2014 is the emphasis on team-based care. Team-based care was a requirement in 2011, but it was not a must-pass. In 2014, you still saw requirements for team-based care with some enhancements, but it now became a must-pass. So it gives you some insight with the change of thinking for NCQA and just kind of the change of landscape in the healthcare environment. So there will be some changes there from 2014 to 2017, just like there were changes from 2011 to 2014. The key thing that you want to know with 2017 is that the process for recognition will change. How you get recognized will be changed. Now, you take the standards and guidelines, you respond to the different deliverables, you submit your documentation through your survey tool. That will still remain partially true, but there'll be a large component of the recognition process that will now be virtual, where you'll have an opportunity to share your screen with a reviewer. You'll be able to have interaction with a reviewer. You'll be able to have communication, and you'll have to demonstrate some key functions of your practice relative to enhanced access, continuity of care, population management, care planning, care management, care coordination, and performance monitoring and improvement. So you'll have more interaction with your reviewers. It won't be just a mystery person that you submit your application to and you get a score back and you don't necessarily know where these comments came from about how well you did or areas of opportunity. You'll actually have interaction with your reviewer. NCQA has been piloting this new model since 2015 in preparation for the 2017 launch. So in a nutshell, just be aware there's some major changes coming in 2017. So if you want to get your application in under the 2014 standards and guidelines, now is the time to begin thinking about that. Key things to know about patient-centered medical home recognition. There's a lot of research, that's starting to happen, which I think is the reason why a lot of reimbursement programs have started to follow. But there's a lot of research out there that may define, that patient-centered medical home is working well. Maybe it worked better for certain populations. Maybe it worked better for certain measures. Maybe it didn't. I mean, you can pretty much, look at research and find anything that you want. The key thing to know about the model is that the effectiveness of the model is based on how you implement it. You definitely want to make sure that you have a strategy and a structured approach to how you're implementing the work. If you want to transform, then you have to use the standards and guidelines as an opportunity to transform and not approach the standards and guidelines as just a recognition program. The standards and guidelines are not going to jump up, paint the walls, and change your practice. There's a level of effort that you have to put into what NCQA is asking you to do to truly see the true essence of what the program is intended to do. So special emphasis on how. Avoid allowing recognition to be a barrier to transformation. And I notice practices a lot of times get so bogged down on trying to meet what NCQA is asking for that they're not personalizing the information and making it relevant to how they do business and what are the areas of opportunity based on what the standards and guidelines ask for. So please make sure that you pay special attention to how is this helping us to transform, and what are those key questions that we need to ask in reading the standards and guidelines to make sure that we're doing that. The recognition is good for 3 years. Streamline renewal is an option for practices with a level 2 or higher. So here's another reason why you want to make sure that when you go for the recognition that you go for a level 2. In 3 years, you're going to have to renew. If you're not a level 2 or higher, you're going to have to reproduce the whole effort in order to maintain your patient-centered medical home recognition. What I mean by the whole effort, you're going to have to do every single factor, every single standard, and respond to all those deliverables all over again. So you're going to have to recreate that energy. If you're a level 2 or higher, right, you don't have to. You're eligible for a streamlined renewal. So in total, I believe there's 27 elements in all of patient-centered medical home. The streamlined renewal is only focused on 17 of those elements, and a large portion of those elements you can attest to. And for the things that you can attest to, you will have to provide documentation to demonstrate that you've been operating as a medical home throughout your recognition period. So a lot of perks for getting the level 2 or higher. And last but not least, in terms of things to know about PCMH recognition, NCQA does audit. Audits are real, and I think they try to audit maybe about 5% of recognized sites every year. So try to make sure that you're using integrity in how you're going about the process. Make sure you're maintaining the documentation and using it, and you shouldn't have that worry. So strategies for PCMH implementation, success. What are some key things that I can tell you that will help make your process a transformative process and give you the best opportunity at success? First and foremost is to assemble a leadership team, okay? And avoid delegating the PCMH responsibility to one person. It's always a little frustrating when you walk into a practice who's interested in doing patients in a medical home. They're like, here's Jim, he's responsible for the PCMH stuff. That's not. This is just a prime example of how you implement the work. Matters. You really want to try to make the PCMH implementation process a team effort. You want to try to involve your staff and really engage them. If I'm working with a patient-centered medical home, they've gotten recognized, and I go to the front desk and I say, well, how's the patient-centered medical home work been going? And they're like, what? What's patient-centered medical home? What is that? Your whole practice should know that you're working towards patient-centered medical home recognition. Your whole practice should participate in some degree of training relative to their job function in order for the practice to operate as a medical home. At the end of the day, it's the people who are doing the work. So if you don't engage the staff, then you'll never operate as a medical home at the level that the program is intended for you to do. So assemble a leadership team, engage your staff, and establish regular meeting times to discuss transformation and NCQA requirements. And so you want to read the requirements. You want to have meaningful discussions about what you currently do, what you don't do, what you need to do, and just observe where those areas of opportunity are. And you also want to ensure that sustainability is the silver lining in everything you do. Again, this is not an exercise in recognition. We are trying to transform. And in trying to transform, you have to pay special attention to sustainability at the onset, not once you finish your recognition process, not once you produce all the documentation. The time to think about sustainability is as you progress through the engagement. So common questions, about patient-centered medical home. First and foremost is cost. I've heard that doing this work is going to be a tremendous cost. If you already have an EMR system, you already have meaningful use. This system is working well for you in terms of being able to produce, reports, being able to produce, care plans, and has evidence-based guidelines integrated into how you're documenting patient progress. Chances are there'll be no cost to you associated with your EMR system. A lot of vendors, do have patient-centered medical home reporting modules that you can purchase. And I've worked with some practices that have elected to do that, and it's worked really good and made the process of producing reports really easy, not only for the sake of recognition, but the sake of different population management campaigns within the practice. So your EMR potentially could be an area where, you may identify that, hey, our EMR system is not performing at the level that we need to, and this may be an opportunity to see what improvements that we can make. So just something to think about there relative to cost. And then obviously the allocation of staff time and resources. I always recommend for practices to meet at least 1 hour, a week, and then between those meetings, assign different tasks to different people who are part of that PCMH implementation team. And so when you think about just some of the time they spend, to work, on transformation, then obviously that can be attributed, as cost. I highly suggest that you perceive that as an investment. The NCQA application itself, the survey tool that I was speaking of, is $80, and the cost per provider is about $550 per provider. So the recognition is at the site level, and all the providers at that particular site typically cost about $550 a provider. So there is a cost for the application. If you decide to work with a consultant, I think that would be an excellent idea. We have a few really good consultants here in the state of Georgia. I encourage you, though, that if you're looking for a consultant, that you confirm the certification as a patient-centered medical home content expert. Very important that if you're working with a consultant, that they are totally familiar with the standards and guidelines, totally familiar with the recognition process, and can give you the best opportunity at receiving the desired level that you anticipate. And then last but not least could be website upgrades and patient portal operations. There will be different deliverables relative to access and how patients are using the patient portal. That some practices say, hey, this is an investment we want to make. Some practices may already have a patient portal, or some practices may not just be ready to purchase a patient portal, and they forgo that, which is fine. But just know if you do that could potentially be a source for cost there. Common PCMH questions in terms of the time commitment. On average, as I said, it takes about 1 year to complete the full engagement. The fastest that I've seen a practice completed is 4 months. The longest that I've seen a practice take is 18 months. Here's something that you want to think about with your engagement time. In general, NCQA has a requirement that when you submit documents to them, reports, examples, screenshots, that none of this information can be older than 1 year. So let's just say you started your recognition process today. You pulled a report, a demographic report that illustrates the number of patients over the past 3 months, over a recent 3-month period. Let's just say you did Q3 of 2015, and this report says, hey, of all the patients we saw over that time period, of those, how many did we record date of birth, race, ethnicity, and language? And then you have a certain performance relative to those key measures. Well, if that report, is reflective of Q3 of 2015, then today that report is up to date. But if it takes you a year, if it takes you over a year to submit, that means when you submit, that report that you did in the beginning of your engagement is now old. And so that's really the point that I'm trying to communicate. Be careful about taking too long to submit, because your documents become old and you run the risk of having to reproduce a lot of that information again. So if you're going for the recognition, I would try to set a goal to get it done, within a 1 year time frame. Leadership team assembly and maintenance. That's really going to be what the rate limiting step is, and really determines how efficiently and how quickly you move through the recognition process. If you've assembled a leadership team, you've maintained that leadership team. That leadership team is meeting on a regular basis to discuss transformation and the different PCMH, deliverables. Then you'll move through the work, pretty quickly, and you'll feel really good about the experience that you have. If you don't have a leadership team, you've assigned this to one person, then that's when things, get unpredictable. I've never understood practices that assign this type of work for one person and expect one person to be in charge of transformation, one person to be in charge of culture change, one person to bring back all of the messages that Patient-Centered Medical Home offers to an entire, practice staff. And so I understand that some environments where you may have limited staff and maybe one person may be all you can delegate, and that's fine. I'm not saying that there's anything wrong with it, but if you have the resources to devote to the work, then use those resources, because you want different hands on deck to participate in this engagement, because different parts of the practice will bring unique perspective that ultimately will bring everybody together. And then also EMR proficiency. The more proficient practices are in using their EMR system, if they have meaningful use and they're truly meaningful users, then typically their experience going through the PCMH engagement is a lot easier, as opposed to practices that have a beginner or intermediate level of expertise relative to using the EMR optimally. So here's just a great visual of what the nationwide landscape is for PCMH incentives. And this has to be very encouraging. If you're wondering, if you're considering whether or not I want to do patient-centered medical home, or what are the benefits to the to the provider, then this should give you some degree of encouragement to know that, hey, the landscape is moving in the right direction, and everybody's starting to catch on that, hey, this is a great model. It improves quality, it reduces costs, it enhances the patient experience, and there's an opportunity for us to incent providers for this level of performance. But it looks like the nation is starting to catch on, so hopefully we see more of the same as we progress. And again, this calendar was from 2014, and in 2013, this number grew from 35 to 42. So hopefully we continue to see the trend in the upward direction in terms of states that are having different PCMH incentive programs. So what's the PCMH reimbursement landscape in Georgia? So if I'm a provider, I'm considering doing patient-centered medical home, I think it's a great opportunity for my practice and for my patients. What's the benefits, so to speak? Well, we talked about some of the practice, benefits, and we talked about some of the benefits for patients. But in Georgia, we actually have a healthy landscape for PCMH reimbursement. A lot of your care management organizations have PCMH incentive programs. On the commercial side, the Blues have an enhanced personal health care program that's pretty popular, where PCMH recognition will be factored into your reimbursement based on utilization and quality of care performance. A lot of your care management organizations are doing some type of enhanced reimbursements for certain billing codes, or certain codes where you can get an enhanced rate, and I've seen all the way up to 10% for some codes. So I would definitely suggest that you reach out to your different care management organizations for your Medicaid populations and ask your provider, representative, what they're doing for patient-centered medical home recognition. You may be surprised at some of the things that are out there. I've seen some other care management organizations that are doing an adjustment to your contracted rate, where if you have patient-centered medical home recognition at a level 3, it'll be a 3% increase to your contracted fee-for-service rate, 2% for level 2, 1% for level 1. And then also, as I stated, earlier, and the great thing about this, regardless of who your payers are, implementing the medical home helps all your patients. And so if you're a part of
Gerald, did I lose you?
It looks like he's still green. It might have, maybe you actually muted Gerald.
No.
Okay, he's offline, so that does look like we've lost him.
Okay. Yes, if you contact him and get him back on. Meanwhile, I will ask the audience if you have any questions. This is a good time to go ahead and type them in. Gerald, are you there?
Yes, I'm here.
Hey, I lost you for the last 30 seconds or so.
Oh, wow. Okay.
So we still have you on the screen on the PCMH reimbursement landscape in Georgia slide. If you'll just pick up, you are about 3/4 of the way through.
Okay. Awesome. So I'll start with the third bullet. I was making the point that in terms of how a lot of care management organizations or different payers across Georgia, how they're reimbursing. One of the ways is that they've identified certain preventive billing codes where they're providing an enhanced reimbursement for those particular codes. Another way is an adjustment to your contracted fee-for-service rate, where if you get a level 3 recognition, you can get a 3% increase on your contracted fee-for-service rate. And then the same thing for level 2 and level 1, which will be a 2% increase and a 1% increase. And in addition, I was making the point that regardless of whoever works with you, if you have a certain payer that works with you to become a patient-centered medical home, that work will help all of your patients. And so you'll benefit in anybody's incentive program that you participate in. You'll have an opportunity to benefit, across the practice. And so typically, if you reach out to your payers, ask them what they're doing for patient-centered medical home recognition, ask them what the reimbursements look like, what are the percent increases. You can do some quick math and get a really quick estimate of what the ROI will be immediately as a result of just having the patient-centered medical home recognition. So a lot of great things, happening in Georgia for practices that are moving to a more patient-centered approach to delivering care. So PCMH support in Georgia. Georgia High Tech is a great resource to use if you're looking to get patient-centered medical home recognition. They have patient-centered medical home certified content experts, and in addition, they have experts who are qualified in meaningful use, which is like a double whammy. It's really good to get a person that understands patient-centered medical home, and they have specialized expertise in meaningful use. There's a lot of strategy that's involved in implementing the medical home model correctly, and having those two unique skill sets will be very valuable. So I would definitely consider Georgia High Tech. In addition, the Georgia Academy of Family Physicians has a PCMH University, and they have rolling cycles where they enroll different practices into the program and work with them to help them become patient-centered medical homes. Amerigroup, we also work with practices. We were one of the first CMOs and just payers in the state that invested in consultants and trained them to become patient-centered medical home certified content experts to work with the greater provider network, the greater Medicaid provider network throughout the state to help them become patient-centered medical homes. So we're always looking to identify, good groups. We've been doing the work for a while, so we're definitely interested in working with groups that just need some help to get started. But readiness is something that's very important to us. So we're looking for practices that are really demonstrating some degree of readiness to do the work, because our resources are limited in terms of the number of people we can deploy to different parts of the state to sit with you shoulder to shoulder and do this consultation work. There are other CMOs and private payers that may be involved in some consultation opportunities. So I would definitely, again, reach out to whoever your payers are. And then also NCQA maintains a certified content expert directory on their website where you can just select the state, which is Georgia, and you can see all the certified content experts that have been all the certified experts in the state who could possibly be of service to you. So another resource there. And that's it. Any questions?
Beautiful. Hey guys, this is your opportunity to ask questions. Please feel free to type them in the question box and we'll address those. Excellent education to this audience, Cheryl. You thoroughly covered the program model and, importantly, the emphasis on transformation and sustainability. So it's also very interesting, the reimbursement landscape. Thanks for covering that as well. I'm proud of Georgia. We are on our way and looking good.
Sure.
I am checking to see. I don't see any questions. I told you covered it very well. I'll open this up. Are there any comments from any of our other panelists at this time? If so, you are not muted. Feel free to make your remarks before I close this out. Oh, and one more reminder to the audience, this presentation you can download it from the GoToWebinar panel. In handouts, click on handouts, and you'll see Gerald's presentation there, and you can have those slides. Otherwise, you'll be sent a link in a week with the direct link to the course materials and the recording on the Georgia High Tech Online Training Center. So are there any other comments or questions? Okay. If not, Gerald, thank you again, and thank you attendees for being with us today. Everyone have a great day and a great rest of the week.
Thanks for having me, Sherry. Thanks for having me, guys. Take care.
Thank you.
All right.
Great presentation.
Thanks very much. Appreciate it.